Applied Kinesiology, Session 7 continues with knee dysfunction. So these two slides show the knee joint, the basics. You've got some bursa in there, and you can see the ligaments. We've got some slides that are a little bit better down the line here, but kind of get oriented as to the actual mechanism. Stepping back, big picture is the knee is part of a kinetic chain involving the foot, the knee, the hip, the spine, the pelvis, and in some cases the opposite shoulder. And so a knee problem or a presentation of knee pain or a specific knee injury will lead us to evaluate biomechanics, i.e. muscle function, north of the knee and south of the knee. So in order for a knee to be functional, you've got to have a stable trunk, abdominal muscles, pelvic balance, pelvic muscles need to be in balance, and of course optimal foot and ankle function. I broke down the muscles here like we did for the shoulder just to kind of get our thinking clear. So pelvic, knee, ankle muscles all require pelvic balance, which involves these muscles. The knee muscles more specifically in this category. The next couple slides we've got muscles that just cross the hip are going to be iliacus, glute med, max, pectineus, superior and inferior gemelli, obturator internus, externus, and quadratus femoris. And I forgot to add on this list the adductors, the adductor longus, brevis, and magnus. Muscles that cross the hip and the knee are going to be rectus femoris, hamstrings, tensor fascia lata, sartorius, and gracilis. And these are specifically our muscles we'll be evaluating when we have knee issues. Muscles that just cross the knee, the vastus medialis, lateralis, intermedius, and popliteus. And the knee and the ankle, gastrocnemius and plantaris. Muscles that cross the ankle only, just as a review, soleus, the lower part of the calf muscles, tib anterior, posterior, flexor digitorum longus, hallucis longus, extensor digitorum longus, extensor hallucis longus, proneus longus and brevis, and proneus tertius. Quick little drawing here so we can refamiliarize ourselves with the specific ligaments of the knee. Get the patellar tendon, very important, loaded with proprioceptive, or loaded with proprioceptors, a common site of IRT problems. So medial collateral ligament and of course the cruciate ligaments, they get a lot of attention. Knee muscle correlations. This is an AK correlation. So you look in the right side there, the right side of the equal sign is going to be the muscle that you'll find weak, often with these associated joint dysfunctions. And I do find these all the time. These are really reliable. Now, these muscles can be weak for a lot of other reasons too. But one of the things that you want to look to on that list, of course, is these types of joint dysfunction. First type of knee dysfunction we'll talk about is, and we'll talk about three main ones that we'll be looking at in this section. Popliteal syndrome. This is where you've got a dysfunctional popliteus muscle. And the popliteus muscle, of course, is responsible for the medial rotation or internal rotation of the tibia relative to the femur. Problems with this muscle can cause a lot of joint problems, but it can also cause problems in the back of the knee. And it can be caused by other problems in the back of the knee, such as trauma or a Baker's cyst can interfere with popliteal function because it lays right over the muscle. So hyperextension injuries can damage it. Often the calves will appear hypertrophied because they're not draining well. It's because the lymph is being impeded. Some other factors to look for: high heels causing anterior talus, chronic ICV. Any kind of toxicity, of course, can cause sluggish lymph drainage, which can cause congestion in the muscles. Typically, when a patient presents with pain going upstairs, you want to think specifically glute max. If they're having pain walking downhill or downstairs, you want to specifically check quads. Once again, toxicity. Other common causes, tight TFL can interfere with the internal rotation of the tibia. Various bursitis problems can interfere with any place in the knee because there's bursa all around that pad that isolate muscle layers and tendons from bone. So popliteus syndrome tests. So we want to use the popliteus test that we learned several sessions ago. It's very reliable if you get good at it. The muscle could be weak for it can respond to a fascial flush test, i.e. the muscle can test strong, but if you give it a quick stretch, it weakens. It can also weaken to a strain counter-strain test, and that's where you can have the muscle, you contract the muscle, and then let it rest, and then immediately test it again. And a lot of times, a strain counter-strain muscle will weaken. A reactive muscle, you can find the popliteus acting as a reactive muscle to the quads, sartorius gracilis. And then, of course, I find a lot of the time origin insertion is a common cause of dysfunction. Basically, you want to find all the weak muscles and fix them around the knee. And the same thing we do with all AK approaches to joint problems. The second syndrome we're going to examine is patellofemoral syndrome. Basically, pain around the anterior part of the knee, the kneecap. It can extend down into the tibia, it can refer up into the quads, but it'll be pain right at the kneecap. This is also called runner's knee or jumper's knee. It's seen a lot in sports. They'll have sharp pain intermittently and then like a dull, constant pain when these get really irritated. They flare up with activity, they calm down with rest, often associated with chondromalacia or degeneration of the patellar cartilage. What really contributes to this particular problem is going to be tracking problems of the patella. The forces, especially when you see one and not the other, the forces of the quads will cause the patella to, puts a lot of pressure on the patella, and the patella has to seat properly into the anterior femoral fossa. If the patella is not tracking properly, that's going to cause excessive motion and irritation, which can lead to to inflammation. So basically, we've got a muscle imbalance. So you can have problems with pelvic muscles, which we call descending chain problems, involving hamstrings, gastroc, and quads. You can have distal problems, coming up from excessive pronation, tight Achilles, tibial torsion, which is more of an anatomical variant. All of these can contribute to the problem. A very specific test that we use for quad imbalance is a straight lateral and medial, vastus lateralis and medialis, respectively, test. And I'll demonstrate this test in the workshop. This is how we can break it down even further, upper, middle, and lower tests for the vastus lateralis to really pinpoint where the problem is. But in short, with a knee problem, with a hip problem, with a shoulder problem, find and fix the muscles. Find out why the muscles aren't firing properly. Same thing we do throughout our AK approach. Next, the third condition that we'll talk about that's very common in how we can help this problem with applied kinesiology is meniscal injuries. Here's a quick review picture of what it looks like from above. The medial meniscus, of course, is larger because that's where it has to accommodate the medial tibial motion in the screw home mechanism. Meniscal injuries are acute injuries are typically caused by a twisting impact. There's an impact on the knee as the knee is twisting. And then, of course, they can also develop from chronic abnormal motion and abnormal support, or old injuries resulting in ligament laxity, and, of course, IRT patterns and scar tissue. Those can cause a recurrent, chronic wearing kind of injury to the meniscus. They're common with hyperflexion injuries like sports injuries. These are some bullet points, kind of saying again what I said before. Instability can cause meniscal tears, and direct trauma can cause meniscal tears. Often we won't see the acute meniscal injuries as much as we'll see chronic problems. These are some of the common presenting symptoms: giving away, locking, catching, swelling, intermittent effusion, and of course orthopedic tests, which will reveal pain with rotation of the tibia coupled with flexion, and of course direct palpation. Joint effusion, medial joint space tenderness, common with medial meniscal tear. This is kind of saying the same thing here. Standard orthopedic treatment can be all the way from they leave the tears alone, the conservative treatment if they're judged to be not too bad. Can go in and repair the meniscus to a certain degree. Partial meniscectomy, which removes the damaged part but leaves the rest, and in severe cases, total meniscectomy. meniscectomy. It depends on the age of the person, what they're involved in, whether it's acute or chronic, whether there's other kinds of instability. That's what surgeons will base their decisions on. Some meniscal tears are not symptomatic, so the tears just aren't causing enough of a problem to alert the nervous system. Often these kinds of tears can get by without surgery. Partial tear, split tears, full thickness, small tears can often be left alone. Inner rim tears, and often when the tears are associated with degenerative changes in the joint, it's better to leave the tears alone. So 2 criteria: if the symptoms are intermittent, they seem to come and go. A lot of times you can just leave the meniscus there. If there's joint effusion in the joint, severe pain, then a lot of times surgery is the key. So 75% statistically of meniscal tears require only part of the meniscus to be trimmed away. The goal is, of course, to leave as much of the meniscus as possible. So that is all we have for knee slides right now. We'll be going over the knee in depth during the workshop.